Kirtivardan sir. Hello, Kirtivardan sir. Kulkarni sir.
Namaste, sir. Namaste.
Good evening. Good evening. Dr. Kirtivardan Kulkarni sir.
Start,
How's it?
Manu, sir. Okay. Shall I start? Okay. Good evening, everyone. A warm welcome to all of you for today's Public Health Subcommittee of IMA KSP meeting. On this warm evening, hearty welcome to all. On behalf of Public Health Subcommittee of IMA KSB, I, Dr. Padma Prakash, Chairman, welcome our Honorable President of IMA KSB, Dr. Srinivas, sir. Welcome to you, sir. And a warm welcome to our Secretary, Dr. Karunakara, sir. Our guest speaker, Kirtivardan Kulkarni, sir. And my colleague, Dr. Kagalkar, Dr. Anuradha Madam, a past President, beloved Dr. Shivakumar Lakkol, sir. And all the dignitaries of IMA KSP here. Warm welcome to all of you. Now I request Dr. Karunakara, sir, to do IMA prayer. Sir, over to you.
Suresh Martira.
Our chairperson idar, sir. Introduce ಮಾಡ್ತಾರೆ speaker na.
Okay. Just a moment. ಹೊರಗಡೆ ಇದೆ ಅದಕ್ಕೆ just trying to see ಒಂದು ನಿಮಿಷ. Just a moment. ಒಂದು ನಿಮಿಷ ಓಪನ್ ಮಾಡ್ತೀನಿ. Okay. I'm starting now. Good evening, everybody. We're starting the program with IMA prayer. Thank you so much. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಪ್ರಾರ್ಥನೆ. ಎಲ್ಲರೂ ಸಂತೋಷವಾಗಿರಲಿ, ಎಲ್ಲರೂ ಆರೋಗ್ಯವಾಗಿರಲಿ, ಎಲ್ಲರೂ ನೋವಿನಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲರೂ ದುಃಖದಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲ ಆಸೆ ಆಮಿಷಗಳನ್ನು ಮೀರಿ ಗುಣಪಡಿಸುವವರು ನಾವಾಗಲಿ. ಜೈ ಹಿಂದ್, IMA ಚಿರಾಯುವಾಗಲಿ. Thank you so much. It's back to you, Dr. Padma. Please take over. Thank you.
Thank you so much, sir. Now I request our Honorable President of IMA KSB, Dr. Srinivas, sir, to deliver the presidential address.
Yeah, good evening, everyone. So, Secretary, Honorable Secretary, Dr. Karunakar, and our immediate past President, Dr. Shivakumar Lakkol, sir, is there. And Chairman, Padma Prakash, Secretary Kagalkar, past Vice President, Dr. Anuradha is there. And Rajendra Prasad, some very important person. So he has done tremendous work last time we had panel discussion. He has done very well. And very special guest, Kirtivardan Kulkarni. So he came to speak, deliver the talk about tobacco, anti-tobacco this one, because with respect to Anti-Tobacco Day, International Day. So he came here. I am very happy to everyone here, to welcome everyone, and especially Dr. Padma Prakash, sir, very rightly she is taking that into account. Especially last time also she did a very good program, and this time also with respect to Anti-Tobacco Day, she has selected this. I am very happy that everyone knows that what's the effects of tobacco, and what about this one? How 100% we are not able to reduce it. So many this one criteria are there, so many other issues are there to this one. Every year, so many talks they are arranging, and I'm very happy that in all our state, so many IMA branches they are conducted, that even anti-tobacco programs, jatas with respect to, and to create a little bit awareness to the public. They have done a lot of programs. I'm very happy also. I'm very thankful to them. I acknowledge the work, whatever IMA local branches they have done. Really, it's fantastic also. And without taking much time, so I'll ask our Dr. Padma Prakash to continue this program. Over to you, madam. Thank you. Over to you.
Thank you so much, sir, for your informative and kind words. It's our responsibility being the team of Public IMA, Public Subcommittee. So every month, second Tuesday, we are conducting very useful information, as all of you are aware. Now I request Dr. Suresh Kagalkar to introduce our guest speaker. Thank you, Dr. Kirtivardan, for kindly accepting our invitation. Because 31st March was No Tobacco Day. So as all of us, we are aware that choose life or not tobacco, breathe easy, live better. These are the proverbs we have. And regarding the theme of 2024 No Tobacco Day and March 31st, protecting children from tobacco industry interference. It's a very wonderful topic because the next generation, today's children is next generation. So thank you once again. And over to you, Dr. Suresh Kagalkar, for your kind words.
Thank you very much, madam. Yes, on the behalf of IMA KSB and this Public Health Forum, as madam has told, every month we are doing such a wonderful program. Every month with a different speaker with a different subject. This time we have chosen our own person from the Bijapur, Dr. Kirtivardhan Kulkarni, who is a professor and HOD in the Department of Respiratory Medicine, Sri B.M. Patil Medical College, Bijapur. So he's a colleague also, and we are having a frequent contact. And whenever cases are there, we are referring to him only. So many cases, especially in the northern city, especially in the where the environmental, the role of environment is very important for the health. So public health as well as this tobacco has got a very social relation is there. So that is how we have chosen this topic. And also May 31st was the No Tobacco Day. So on this behalf of this No Tobacco Day, May 31st, we have chosen this topic as well as the good speaker who is going to deliver a good the lecture. Dr. Kirtivardhan Kulkarni sir is a professor and HOD Department of Respiratory Medicine, Sri B.M. Patil Medical College. He is serving for the last 5 years as a HOD, and he has done the various positions. He was a assistant professor, associate professor, and the professor. Sir has done MBBS from the Devaraj Arts Medical College, Kolar, and also he has done DNB Respiratory Medicine in the JSS Medical College, Mysore, and also he has taken a diploma in allergy and asthma in the different area, and sir is specialized in the chest and TB area. So a lot of experience and lot of publications and many articles with sir. I no need much introduction, and sir will deliver a good lecture. And let us all, so because this tobacco effect is on all the system, not only respiratory, even intestine and kidney and other areas also. Let us, all the doctors of the public health, let us join and we'll listen the important hints of the Dr. Kirtivardhan sir. Over to you, Dr. Kirtivardhan Kulkarni sir.
Thank you, sir. Thank you, Suresh sir, for the kind introduction. So I thank IMA for giving me this opportunity to give a lecture on tobacco, and I'd like to thank Public Health Subcommittee, IMA Karnataka State Branch, for giving me the opportunity. So I'll start my presentation. So greetings from BLD deemed to be University, Sri B.M. Patil Medical College. So today's topic is on No Tobacco Day. Theme for this year is protecting the children from the tobacco industry interference. So I'll be dealing with the manufacturing of the tobaccos, different types of tobacco uses, health hazards, epidemiology, government regulations, de-addiction, and cessation. This will be an exhaustive talk which covers mainly de-addiction and cessation of TB, cessation of tobacco in detail. So coming to the introduction, tobacco, its scientific name is Nicotina tabacum. The active component in tobacco is nicotine. The nicotine is a potent euphoriant. It has more active euphoric properties than drugs like cocaine, amphetamine, and morphine. It ameliorates the anxiety and reduces the perception of pain, mitigates the symptoms of depression, and includes a sense of well-being while causing a state of arousal. Tobacco smoke is a complex mixture of different size particulate matters, suspended volatile and semi-volatile compounds, and the consumption gases. These compounds are associated with well-documented cardiopulmonary complications in smokers. So, coming on to how the tobacco is used. It is used in smoking and smokeless way. And in smoking, there is cigarettes, then BDs, cigars, hookah, chutta, pipe. Whereas in smokeless, it is pan beetle, kaini, gutka, zarda, all these things. Some use it as a snuff. So these are smoking users of the tobacco and smokeless users of the tobacco. So these are the different products available, easily available everywhere in India. These are cigarettes, BD, cigars, hookah, snuff, khaini, zarda, gutka. Coming to the epidemiology, India is the second largest producer as well as the consumer of the tobacco products. According to the National Survey on Adults in India, 47% of the males and 14% of the females are current tobacco users. Among the male tobacco users, 30% are smokers, whereas 70% are using tobacco other than smoking. Though in adults, the tobacco use among males is 10 to 15 times higher in females, but in adolescents, this gap is reducing. In developed countries, the tobacco use is showing a decreasing trend. The pattern of tobacco use in India. The use of smokeless tobacco is much more prevalent than smoking tobacco. Prevalence of smokeless tobacco is 26%, is almost twice as the prevalence of that of smoking, that is 14%. More than 75% of the tobacco users, both smokers as well as users of the smokeless tobacco, are daily users of the tobacco. That means they use the tobacco on daily basis. Khaini, that is the tobacco lime mixture, is the most commonly used tobacco product in India. BD is the second most commonly used smoking product in India, followed by cigarette and hookah. Mortality has been associated with tobacco. Almost half of the people who use tobacco are killed by tobacco-related diseases. WHO has estimated that 10 million deaths will be caused by tobacco, were caused by tobacco in 20th century, whereas in 21st century, it is expected to increase to 1 billion deaths. So tobacco-related diseases are important cause of death among the middle-aged men in the, India, who are the main working force of the country. Almost 25% of the deaths in this group are due to tobacco-related diseases. Factors responsible for smoking are especially early life exposure. That is why this year's theme is protecting the children from tobacco industry interferences. So mainly the environment factors like living in an area that does not restrict the smoking, or genetic factors play important in the continuation of smoking. Passive smoking in the childhood is considered as a risk factor for development of asthma in later adulthood. Uncontrolled asthma is also associated with parental smoking, especially in children. Asthmatic symptoms sharply decline after the environmental tobacco exposure is controlled. So type of smoking and the harm. BDs produce 3 times more carbon dioxide, nicotine, and 5 times more tar than regular cigarettes. BD smokers have a 3-fold higher risk of oral cancer compared to the non-smokers, and also increased risk of lung cancer. Hookahs, a popular form of smoking in rural areas of India, is also linked to lung diseases and cancer. Based on the nicotine content, it is proposed that the equivalent of 1 cigarette pack year or 20 cigarettes year are taken as 43 BDs per day per year. 1 packet of BD contains 24. So nearly 43 BDs means almost 2 bags of BD. So even though each BD stick has an average of 0.46 times the nicotine content that when compared to cigarette, a longer abstinence as compared to cigarette is required to bring nicotine level to a normal due to deeper snuff. That means when the person is smoking a BD, to keep the butt burning at the front of the BD, the person continuously smokes. Whereas in cigarette, a person takes a puff, then he waits for some time before going for the second puff. During that time, the front of the cigarette is still burning. Whereas in BD, to keep it burning, the person continuously takes a continuously has to smoke the BD. With the carbon monoxide content of the BDs being 4.5 times that of cigarette, it is advised that the minimum duration of cessation of smoking before operative periods is minimum of 24 hours as compared to 6 hours for cigarettes. So how does the nicotine act? The nicotine exerts its biological effects on nicotinic receptor, a subset of cholinergic receptors. In the brain, 9 alpha 3 beta receptors are expressed. Nicotinic receptors are ion channels. binding of the nicotine to these allows the influx of the calcium. This in turn modulates the release of neurotransmitters like dopamine. So behavioral response to nicotine results from action of many neurotransmitters, but dopamine is believed to be the major mediator of nicotine effects. Though nicotine, the primary psychoactive component of the tobacco, activates the reward pathway in the brain, which reinforces the behavior of smoking. So the dopamine release in the brain results in release of dopamine in the reward pathway. This leads to sensitization. With repeated exposure to the nicotine, the brain becomes sensitized to the effects of the drug, leading to increased cravings and a decreased ability to resist smoking. Withdrawal symptoms, especially like anxiety, irritability, and depression, can occur when the person tries to stop the nicotine use. So, coming on tobacco smoke, when the nicotine enters the body, it acts on the ventral tegmental area, nucleus accumbens, which releases the dopamine, causing rewarding effect. So, whereas the withdrawal symptoms, these are all the different withdrawal symptoms which I'll be covering later when the person is trying to quit the smoking. So, tobacco is attributed to the deaths. So, most of the deaths are coronary artery diseases, cerebrovascular accidents, COPD, lower respiratory tract infections, cancers, and other tobacco-related diseases. So, coming on to the different types of smoking, especially in tobacco, which is used in a smoking form, there are different types of smoke that are there. First one is the mainstream smoke. This is a smoke that is directly inhaled by the smoker and then exhaled into the environment. This smoke contains a mixture of chemicals such as nicotine, tar, carbon monoxide, and other harmful toxins. Next is the side stream smoke or the second-hand smoke. This is emitted from the burning end of the cigarette or BD while not being smoked. This is called as side stream smoke or second-hand smoke. Both mainstream and second-hand side stream smoke contain similar components, but the contents vary. The side stream smoke is 3 to 4 times more toxic per gram of particulate matter than the mainstream smoke. The toxic chemicals of the second-hand smoke stick to the rugs, curtain, cloths, food, furniture, and can remain in the room for weeks or months after someone has smoked there. That means the effect of the smoking lasts for weeks and months there. Then the tobacco smokings that build up over a time on the surfaces of the room and material is sometimes referred to as third-hand smoke. This is approximately 50%, which is associated with cancers. So coming on to the contents of the smoke. So the mainstream smoke gaseous part is 95%. This includes carbon monoxide, whereas particulate matter is 5%. That is nicotine, nornicotine, anatobin, and anabasine, and tar, that is nitrosamine and benzopyrene. It contains many carcinogens like naphthalene, pyrene, benzopyrene, vinyl chloride, cadmium, urethane, toluene. Whereas side stream smoke, that is when the person is not smoking, that time the gas that is emitted from the burning end of the BD or a cigarette, that contains 2 times more nicotine, 5 times more carbon dioxide, 2 times more tar, 73 times more ammonia, 3 times more benzopyrene, that is cancer causing substance, and substantially more cadmium. So these are all associated with the respiratory diseases, especially COPD, exacerbations of asthma, discomitated interstitial pneumonitis, respiratory bronchiolitis, eosinophilic granuloma, community acquired pneumonia, and lung cancer. So the WHO has defined who is a smoker. A smoker is a person who smokes any tobacco products entirely or partly made up of leaf tobacco as a raw material. Ever smokers means a person who has smoked more than 100 cigarettes during their lifetime. Then a light smoker, a smoker who has confessed consuming 1 to 3 cigarettes per day. Moderate smokers, 11 to 19 cigarettes. Heavy smokers, more than 20 cigarettes per day. A current smoker. Who is a current smoker? A person who confesses to smoking part or all of the cigarette during the 30 days preceding the interview and has consumed more than 100 cigarettes in his lifetime. Who is a former smoker? A ever smoker who has not smoking at the time of interview. Then who is a never smoker? Never smoker is a person who who has neither smoked any time in the interview or nor consumed 100 cigarettes in his or her lifetime. Now coming on to the contents of BDs and cigarettes. When compared, the tobacco content per stick is 721 milligrams in cigarettes, whereas in BDs it is 187. But the percentage of smoke per stick is 51% in BDs and 87%. But the nicotine content compared to BD is 26.9 milligrams, whereas in cigarettes it is 14.8 milligrams. Then there are pathological changes in the lung that are produced by cigarette smoking. These include loss of cilia, mucous gland hyperplasia, leading to bronchitis, chronic bronchitis, increased number of goblet cells, increased in goblet cell metaplasia and squamous metaplasia, mucus plugging, destruction of the alveoli, leading to emphysema, pruning of the distal pulmonary arteries, and changes in the pathogen adherence and disruption of the respiratory epithelium. Effects of nicotine on CVS. This causes increase in systolic and diastolic blood pressure, increased heart rate, force of myocardial contraction and excitability, increased myocardial oxygen consumption, increased coronary artery blood flow, and peripheral vasoconstriction. Coming on to the health hazards of the tobacco, the first one is cancer, multiple cancers, right, starting from the head to toe. Most of the cancers are in one way or the other are attributed to the tobacco. Then cardiovascular diseases include sudden death, acute myocardial infarction, angina, stroke, peripheral artery occlusive disease leading to gangrenes, abdominal aneurysms, aortic aneurysms, pulmonary diseases, lung cancer, chronic bronchitis, emphysema, asthma, increased propensity to tuberculosis or community acquired pneumonia. Gastrointestinal, maybe peptic ulcer, esophageal ulcers. Then reproductive disturbances like reduced fertility, erectile dysfunction, premature death, low birth weight, ectopic pregnancy, spontaneous abortion, oral diseases, especially smokeless tobacco, leading to oropharyngeal cancer, leukoplakia, dental caries, periodontitis, tooth staining. Others are non-insulin dependent diabetes mellitus, early menopause, osteoporosis, hip fracture, cataracts, age-related macular degeneration, rheumatoid arthritis. Poor wound healing is also associated with smoking. Then coming on to the smoking cessation. So in general, all smokers try to quit the smoking should be offered pharmacotherapy. There are 7 different types of smoking cessation medication, 5 of which contain the nicotine. They are called as nicotine replacement therapies, and other 2 are bupropion and varenicline. Varenicline, or the combination of the nicotine patch plus SOS short-acting nicotine product appear to be the most effective. However, the choice of the first-line therapy should be governed by the patient preference, familiarity by the clinicians with the medication, contraindications, and prior experience of the patient. Second-line therapies include clonidine and nortriptyline. Bupropion and nicotine replacement therapies may delay but not prevent the weight gain after smoking cessation. It is recommended that the patient start or increase the physical activity, but strict dieting is discouraged because it appears to increase the likelihood of relapse of smoking. All the first-line therapy appear to be safe in patients with chronic cardiovascular disease, but the over-counter nicotine replacement therapy contain precautions which are to be used, especially in a myocardial infarction or a person having an underlying arrhythmias. Individuals with prolonged withdrawal symptoms or those who are unable to abstain in the absence of medication, extended use or a long-term use of nicotine replacement therapy, bupropion, varenicline appears to be safe and effective therapy. So how do you assess? We want to start him on a smoking cessation trial. So how do we assess, and what dose is required? So the most commonly used is Fagerstrom test of nicotine dependence. Here there are 6 different categories, and each one is given a rating of 0, 1, 2, 3. So first one is how soon after you wake up do you smoke your first cigarette? If it is less than 5 minutes, then the person is highly nicotine dependent. If it is more than 60 minutes, that means the nicotine dependence is comparatively less. Then how do you find it? How difficult do you find to refrain from smoking in places where it is forbidden, especially in temples, libraries, cinema, class, etc., or public places? There, if he tells answer yes, that he cannot resist from stopping of smoking, he wants to have a smoke there, then he is given 1. Then how many cigarettes? If it is more than 31, then it is a high dependence. Less than 10, comparatively, it is called as low dependence. Then do you smoke frequently during the first hours of the waking? That means in the first hour, if you wake, if the answer is yes, then the point is given 1. This is for smokeless tobacco, especially people who are using gutka or lying with tobacco. This is mainly for them. This is called as modified Fagerstrom criteria. Then any person who is having a Fagerstrom score more than 7 is likely to benefit from the nicotine replacement therapy or Vernaclin. Whereas if the score is low and if the person is properly counseled, the person can quit smoking without the requirement of nicotine replacement therapy. Then non-pharmacological approaches also help. This is mainly for a person who is attempting to quit. So current recommendation are to assess the smoking and willingness to quit at every visit. In contrast, and on each visit you have to inquire. If it is not inquired, the person will feel the physician does not care if the patient is smoking or not. At that, the physician does not have any effective intervention to offer to him, or that the physician does not think that the patient will be able to quit. These are all the roadblocks for the person to stop quitting. So on each visit, the doctor has to cautiously ask the patient regarding his smoking and his attempt to quit. So all these non-messages have negative effects, particularly as the smokers gradually make a decision to quit. So what we use is a 5A criteria. This is given by the National Cancer Institute model for smoking intervention. First one is ask the patient about their smoking status. Second one is advise the smokers to stop. Then assess their willingness to make a quit attempt. Assist them in their stop smoking efforts. Arrange for the follow-up visit to support the patient's effort within the first week after the quit day. So these are the 5, and this is not the end. So this cycle will keep on repeating until the person is quitting. This is mainly used for a person who is motivated to quit. If the person is not motivated to quit, or the person who is not considering it to quit, we use what is called as 5R strategy. First one is relevance. We will explain him the relevance of quitting the smoking to the kind and the harmful effects of the tobacco smoke. Then risk. We highlight the health hazards caused by the tobacco. Then rewards. If you leave the tobacco, what are all the beneficial effects to you in the form of health, finance, and approval by the family? Roadblocks. Then we ask him what is preventing him from quitting, and especially it may be the withdrawal symptoms, fear, or concern associated with smoking, depression, or lack of social support, enjoyment of the tobacco, are some of the barriers that the client may face in an attempt. Repetition. The physician should ensure that this is a chronic nature of a tobacco dependence and relapses are common. So multiple attempts should be allowed for a person to able to quit. If we don't allow the repetition, the person may not consider quitting it in future. Then pharmacological treatment, as I have already told you, the commonly approved are nicotine replacement therapies, 5 types, bupropion and Vernaclin. Supported guidelines or off-label are clonidine and nortriptyline, and other non-pharmaceutical effects are also there. So coming on to the approved methods, nicotine can be given in the form of gum, patches, lozenges, inhaler, nasal spray. And non-nicotine replacement therapy, where nicotine is not used, these accepted are bupropion and Vernaclin, whereas nortriptyline, clonidine are off-label. When to prescribe? When the score is more than 7 or more than 6 in a Fagerstrom questionnaire, multiple failed attempts, these people will definitely be benefiting from the pharmacotherapy. So if the person gives a history that he has to use the tobacco or smoking within the first 20 minutes after waking, then it dependence high, that indicates high nicotine dependence. These people will definitely improve while by giving the pharmacotherapy. If he uses more than 20 cigarettes or BDs every day, then he will also be benefited from pharmacotherapy. It is available, as I have told, different forms. The concept is to replace the nicotine that would be absorbed from the cigarette and thereby reduce the intensity of the withdrawal. So the nicotine which is present in the cigarette is replaced by either the gum, lozenges, or the nasal spray or inhaler. Then at present, the two forms of chewing gum are available, that is 2 grams and 4 grams. A person, this will help. This will the nicotine is bound to resin, and when the person chews the resin, the nicotine is released in the saliva. He has to try to hold that saliva in the mouth instead of swallowing. The more he holds the saliva containing nicotine in the mouth, the more would be the venous absorption of the nicotine. If he swallows, there will be some local irritation to the stomach, and in some cases it is absorbed in portal circulation, where the high fast pass metabolism in the liver limits the increase in the blood nicotine levels. So the person has to use one piece of gum once in every 1 to 2 hours for just the first 6 weeks after quitting, followed by gradual reduction over the 6 weeks. So usually tobacco cessation program is for 1.5 months. So 6 weeks are considered for effective tobacco cessation attempt. So a 4 mg dose is recommended for people who smoke, who are called as heavy smokers, that is more than 20 cigarettes per day, and a 2 mg dose is for people who smoke less. So the adverse effects are local adverse effects, especially in chewing gum, especially people with temporomandibular disease, trauma or dental applications, or sore jaw or local irritation or ulcer. This gum increases their pain. So then, as I've already told, if the person swallows, there may be some local irritation in the esophagus and stomach, and he may have hiccups. Then on systemic absorption, sometimes people will experience nausea, vomiting, abdominal pain, constipation, and some people's diarrhea, palpitation, and headache. So this is not, so the gum is only for people who are having good oral hygiene, not oral hygiene, who don't have any oral problems, especially dental problems. So for that purpose, we use in them we use lozenges. Lozenges are a chewable form of nicotine. So the not chewable. The moment the lozenge is kept in the mouth, it will start disintegrating into the saliva. Here there is no need to chew the chew like it was in gum. So it provides a slowest delivery but maintains a steady state. So primary advantage, I have already told you, the person who is having a jaw problem or a gum problem or a teeth problem or who is having ulcers in mouth, in them also this can be used. So then we are having what is called as nicotine patch. Here a new nicotine patch will help in preventing the cravings especially, and it maintains a steady state throughout the day. The primary advantage is it is easy to use. Here the person need not always have something in their mouth. Here once the patch is applied to the skin, especially it is put in during the night time, this will provide a level of nicotine that when the smoker becomes awake. So this will prevent, especially as you have seen in the Fagerstrom criteria, if the person is consuming tobacco within the first half an hour of his after getting up, that person is unlikely to quit. So these patches will help in dealing with that problem. So usually we start with a person who is using more than 10 cigarettes. We start with the 21 mg patch for 4 to 6 weeks, then 14 mg pack for next 2 weeks, and then 7 mg patch for next 2 weeks. If the person is already consuming less than 10 cigarettes, we start only with 14 mg and then we move on to 7 mg. Next is a nicotine inhaler. This is a plastic nicotine containing cartridge that fits the mouthpiece. The nicotine is released when the air is inhaled through the device, which is similar in size to that of a cigarette. So this actually mimics a cigarette. So this inhaler recapitulates many of the action associated with smoking, and preparation of this device oral stimulation inhalation, and it may be particularly effective in smokers for whom these behaviors are particularly strongly condemned. That means uh, using this inhaler mimics as if he is smoking a cigarette or a BD. So the person will, this will help the person in simulating what is when he is using BD or a cigarette. So this inhaler helps in them also. But this is mainly associated, some people may be associated with bronchospasm, especially in a reactive airways like asthma. 2 nasal spray per hour for 3 months with maximum of 80 spray per day is to be given. Then we come on to the non-nicotine replacement therapy. In non-nicotine replacement therapy, first one is bupropion. This is an antidepressant. So this is and effective as an aid in smoking cessation. So mechanism of action is potentiating dopaminergic and non-adrenergic signaling. So especially the patient with history of depression will get help from the bupropion. So dose is 150 mg daily for 3 days, followed by 150 mg daily twice daily. Then this is slowly excreted and steady state levels are achieved after 6 to 7 days. So for this reason, after starting this medication, the patient quit date is to be given after 1 week. So first this bupropion has to be given. He may be continuing to smoke or use the tobacco. Once this medication is started, after 8 days, the quit date. That means after 8 days, the person has to stop using the tobacco. Then this is well tolerated drug, but it has some psychiatric issues, especially it predisposes to seizures, or especially it is contraindicated in patients with anorexia nervosa or bulimia. Then Varenicline, this is a partial agonist at the alpha 4 beta 2 nicotine receptors. So this drug binds to the same receptors as that of the nicotine, thereby preventing the nicotine from attaching to the same receptors. The dose is 0.5 mg OD for 3 days, followed by 0.5 mg BD for 4 days, and then 1 mg BD for 3 months. This is also same. We have to keep the quit date 1 week after starting the medication. Adverse effects are nausea, insomnia, visual disturbances, and syncope. This is one side effect which has resulted in a FDA advisory for people who are using heavy machineries. So in them, while giving Varenicline, the patients have to be advised regarding some people may experience syncopes. So for that purpose, whenever you are using heavy machineries, be careful. Off labels, that is clonidine and nortriptyline. Clonidine is an alpha adrenergic agonist active in the CNS. The adverse effect of drowsiness, fatigue, dry mouth, postural hypertension. Nortriptyline is a tricyclic antidepressant. It is sometimes recommended as a possible second-line agent. Again, the adverse effects are drowsiness, dry mouth, and same as other tricyclic depressant, especially they are having CNS and cardiovascular effects, including arrhythmias. Then there are some investigational drugs. Topiramate, this is an anti-seizure medication that is being tried. Cerazine, which is used for Parkinsonism, that is being tried. Some SSRIs, opiate antagonist anxiolytics are also being tried. Now, and one more is nicotine vaccines. They are being tried, but most of them are failing their phase 3 trials, as the antibodies that are produced against nicotine, they in phase 3 trials, especially in human trials, they have not shown any clinical benefits. Now there are different vaccines that are under consideration: Nicvax, CYT002, NIC-QB, and TANIC. So pharmacotherapy for smokeless tobacco users. So nicotine gum is can be easily used. Patch therapy can be used. Lozenges can be used. Then the most important intervention are oral examination and counseling, mainly behavior intervention. So when the now coming to withdrawal, so once the person tries to stop the tobacco, in the first 3 days of the obstruction are usually most difficult. So withdrawal symptoms peak during the first 72 hours and then gradually subside over 3 to 4 week period. So the common suggestion that help the smoker cope with these withdrawal symptoms are: be active, use deep breathing exercises, avoid high risk situations, especially tension giving situation during the first 3 weeks, use plenty of cinnamon gum or a chewable candies or peppermints, then combat strong urges to smoke. The urge to smoke will go away once the whether the smoke one smokes or not. Cravings. Cravings are the most pertinent. They recur long after abstinence, during the second and third weeks of the abstinence, and once they continue they become less frequent. The decrease in frequency is greater than the decrease in intensity, and relapse is commonly associated with concurrent alcohol consumption. Then in some people, especially during the first 3 months, they may experience depression. If the depression is severe, then short course antidepressant therapy and counseling, or sometimes even return to smoking is advised. Weight gain, especially, this is one of the very important reason, a very important side effect, not side effect, one of the causes of stopping of tobacco. There is a weight gain, especially during the first 6 to 8 weeks, but the overall weight gain will be around 4.4 kgs and 5 kgs for male and female over the 10 years. The risk of tobacco smoking cessation, I have already told you, nicotine has some antidepressant effect. So in the person who stops smoking, some people may experience depression, exacerbation of ulcerative colitis. Then some smokers report an increase in cough in the weeks, but if they continue to stop smoking, their cough, chronic bronchitis symptoms, they reduce dramatically reduce within a 1 month. So once the person stops quitting, what are the immediate rewards? The breath smells better, the stain gets whiter, bad smelling clothes, hair disappear, yellow nails disappear, the food tastes better. Then at the 8 hours after 8 hours of quitting, oxygen levels in the blood return to normal. 12 hours, the carbon monoxide levels drop to normal. 48 hours, the nicotine is no longer detectable in body. 72 hours after quitting, breathing becomes easier. 2 weeks to 3 months, circulation improves and lung function increases. 1 to 9 months, coughing, shortness of breath decreases. Cilia gain their function. Then 10 years after quitting, the lung cancer rate, death rate reduces to half. Now a small talk on electronic cigarettes. This electronic cigarette, there is the heat in this cigarette. They heat the nicotine solution to generate a aerosol that is inhaled without consumption of the combustion of the tobacco and its toxic constituents. This is called as vaping. So it has a reservoir, it has a resistance metal coil that heats up, a wick, then a battery. So these are different forms of e-cigarette: disposable, rechargeable, pen style, medium size rechargeable, tank style, a large rechargeable e-cigarette, and pod style e-cigarette. These are all banned in India, but they are still available. Then products, the e-cigarette cannot be rated as safe at present, and some manufacturers provide insufficient or partly wrong information about their liquids. So especially the e-cigarettes have some technical flaws like leaking, accident intake of more nicotine, and possibility of unintended overdose. Health effects: short-term use irritate the airways and lead to allergic reactions. And some people, when they use e-cigarette, they have some flavors like mint or other flavors. So they become addicted to that only. So this e-cigarette, which was thought to prevent the other harmful chemicals of the cigarette or a BD, but by itself it contains formaldehyde, acetaldehyde, acrolein, diethylene glycol, nickel, chromium, and lead. So all these themselves can cause other health effects. Now there is one more entity called as EVALI, that is e-cigarette or vaping associated lung injury. So this will lead to hypoxic respiratory failure, and the patient may develop they may go into the ventilator. Coming on to the landmarks of Indian landmarks in smoking. In Atharvaveda, smoking was described especially using cannabis. In 1566, Portuguese sailors entered the India through Goa and offered the Emperor Akbar to smoke tobacco. Then in 1609, Jahangir taxes the tobacco. In 1975, first legislation of health warning on cigarette pack. In 1981, Prevention and Control of Pollution Act was used, public space smoking. Then in 2004, 3 and 4, COPTA was used to avoid advertisement of any form. 2005, disclaimer on smoking scenes in films. Then 2008, prohibition of public smoking under COPTA. Then 2008, prohibit public smoking 100 yards from any public institution or 500 rupees fine. Then pictorial health warning on cigarette packets started in 2009. In 2012, theater advertisement, especially video advertisement, the most common being a patient by name Mukesh. Then in 2014, Punjab became the first state to ban e-cigarette. Then in 2019, India itself banned e-cigarette. In 2021, the age for smoking was raised to 21 years. So these are all the different tobacco control efforts in India. In 1975, as I have already told, they brought what is called as the Cigarette Act. This cigarette smoking is injurious to health was mandatorily displayed on all the cigarette packages and advertisements. In 1990, Prevention of Food Adulteration Act made statutory warnings regarding harmful effects mandatory on pan masala and chewing tobacco. The central government issued directive of prohibiting smoking in public places, advised state governments to discourage sale of tobacco through educational institutions. Then in 1992, under Drugs and Cosmetic Act amendment, use of tobacco in all dental products was banned. Then in 2001, Supreme Court imposed ban on smoking in public places. Ministry of Railways imposed ban on cigarette of tobacco at railway stations. In 2001, National Human Rights Commission made public health and rights and advocated tobacco control as an essential measure to protect human rights. In 2001 to 3, ban on gutka and sale of gutka and pan masala was imposed in many states. In 2003, cigarette and other tobacco products, prohibition of advertisement, regulation of trade, commerce, production and supply and distribution act of 2003 was implemented. This is called as COPTA Act. This is one of the most important act that governs the tobacco use in the country. It prohibits smoking in public places, prohibition of advertisement of cigarette and other products, prohibition of sale. Even though this prohibition of cigarettes and other products is there, proxy advertisement, also called as surrogate advertisements, are already there, where many of the celebrities, many of the actors who are well known, they give a surrogate advertisement for pan masala or cigarette. So they have used a loophole in this COPTA Act, and they are still advertising. I don't know when this surrogate advertisement will also be tackled by the government. Then the prohibition of the sale of cigarette or other products to anyone below 18 was there. Now it has been increased to 21 years. Then prohibition of trade, commerce, production, supply, distribution of cigarette and other products. As per this, single cigarette should not be sold anywhere. If the person has to buy, he has to buy whole pack. This is not being enforced strictly, leading to many people to start smoking, whereas once they become addicted, the number of cigarettes per day increases. Then pictorial health warnings, testing and regulation, especially ingredients to be declared on the product package, especially the nicotine and tar. Then in 2020, no person shall sell, offer to sell or permit sale of cigarette of any other product to any person who is 21 years or in an area within a radius of 100 meters from any educational institution. Whereas the section 28A, any person who produces, manufactures or supplies or imports illicit cigarettes can be imprisonment for term which may be extended to 2 years with a fine and may be extended to 1 lakh years or both. Sorry, 1 lakh rupees or both. These are different sections and the penalty for each of the prohibitions. So prohibition of smoking public place up to 200. Prohibition of advertisement first offense 1000 rupees and 5000 rupees for second offense. Sale to a minor or around educational up to 200 rupees. Then labeling and packaging. First offense is 2 years and 5000 rupees. Second offense is 5 years and 10,000 rupees. So these are my references. I thank IMA for giving me this opportunity. I especially thank Dr. Srinivas S. Sir, President IMA KSP, Dr. Karunakar, Honorary Secretary, Dr. Padma Prakash, Chairman, and Dr. Suresh Kagalkar, Convener for Public Health Subcommittee, for giving this opportunity. Thank you.
Thank you, Dr. Kulkarni, sir. Very good, informative, and all the corners of the topic has been covered, almost touched, and many information we got. And this is a topic which is relevant to almost all the specialties. It is very much relevant now, and many doctors have joined. Any questions, please ask regarding the tobacco and its product and diseases. Any questions, please?
See, earlier they used to call passive smokers. Now I think they're calling us second-hand smokers, no?
Passive smokers.
Yes.
Yeah. When we
Yeah,
studied
Kulkarni.
it, we used to have us like passive smokers.
Yeah, there is one question. There is a what is the logic behind not selling single cigarettes, sir?
The logic
Not
is if the person is forced to purchase 10 cigarettes, so the person may not purchase the whole pack. So this will indirectly discourage him from continuing to smoke. But selling one cigarette, instead of a packet, if he is purchasing one cigarette, that will still make the person to purchase a single cigarette, and the person will feel it is affordable and he continues to smoke.
Yeah, one question. I have got. I am a urologist and andrologist. The many cases of vast agenesis or vast obstruction, we think that many etiology. Among them, tuberculosis is one of the etiology which is the rarest possible. So, how to evaluate or how exactly the tuberculosis itself? Is it a pathology, histopathology, or any other? The first foremost we investigate is the lung or lymph node. So any what I meant to say that what are the other biomarkers or viral markers or markers in the blood which is available to detect the tuberculosis whenever there is suspicion?
Sir, at present, it is considered, sir, the tuberculosis, the first organ to be affected is lungs. Other forms of tuberculosis are considered as secondary to lung. So, other than lymph node tuberculosis, especially cervical lymph node tuberculosis. So, any other form of tuberculosis that is not in the lung, always if we have to check for a primary in the lungs. And at present, there are no blood investigations to prove that there is an active TB infection, but there is something called as quantiferon TB gold or IGRA, interferon gamma release assay, that only indicates whether the person is exposed to tuberculosis or not. And but now we have what is called as DRT testing. One second, sir. I'll just. Now what we are having is drug resistance testing. So previously we had to culture the mycobacteria. Only after culture is positive, then we would have tested them for individual drugs in a separate culture media. But now what we are having, these were called as drug susceptibility testing, where the growth of the mycobacteria was mainly essential. Without the growth of mycobacteria, we cannot do further testing. But in the newer test, what is called as drug resistant testing, these are genotypic testing. So if the sample relevant to the each organ, for example, if it is lymph node, we can give you a lymph node biopsy or a FNAC. If it is related to lung, if we give the sputum, if it is related to intestine, stools, or if it is related to urological problems, urine, if all these are directly tested on the drug resistant, here the growth of the organism is not required. If there is a bacteria, and if the person is having those genes, if the bacteria is having those genes, the drug resistant testing will immediately tell us two things. One is the presence of the mycobacteria, and second one, whether it is a sensitive mycobacteria or a drug resistant mycobacteria. So drug resistant testings are now gaining prominence because they are very easy to do, and the results are available within 1 to 2 days, especially compared to when we use CBNAT or TrueNAT. But line probe assays at least require 1 week, but the culture methods, they require at least 3 to 4 weeks.
Thank you. Thank you very much, sir. Thank you.
Thank you
Any
so
other
much for the informative and elaborative talk, Dr. Kirtivardhan. Anuradha madam, any questions? Lakkol
Hello.
sir.
ಏನಿಲ್ಲ ಮೇಡಮ್,
ಹ್ಮ್.
ವೆರಿ ಇನ್ಫಾರ್ಮೇಟಿವ್ ಟಾಕ್ ಬೈ ಡಾಕ್ಟರ್ ಕುಲಕರ್ಣಿ ಸರ್. ಒಂದೇ ಒಂದು ನಾನು ಪಬ್ಲಿಕ್ ಹೆಲ್ತ್ ಸಬ್ಸಿಕ್ಯೂರಿಟಿ ನಾವೇನು ಕೆಲಸವನ್ನು ಮಾಡ್ಬೋದು ಈ ಆಸ್ಪೆಕ್ಟ್ನೊಳಗೆ, ನೀವು ರಿಲೇಟೆಡ್ ಪ್ರಾಬ್ಲಮ್ಮು, ಮೆಡಿಕಲ್ ಪ್ರಾಬ್ಲಮ್ಸು, ಅದರಲ್ಲಿರ್ತಕ್ಕಂಥದ್ದು ತೊಂದರೆಗಳನ್ನ ನಿವಾರಣೆ ಮಾಡೋದು ಡಾಕ್ಟ್ರಿಗೆ ಕೊಟ್ರಿ. ನಾವು ಪಬ್ಲಿಕ್ಕಿಗೆ ಏನು ಮಾಡಿದ್ರೆ ನಾವು ಯಾವ ರೀತಿ ಇದನ್ನ ತಡ್ಲಿಗಿಟ್ಲಿಕ್ಕೆ ಆಗ್ತಿತ್ತು, ಒಂದೇದು. ಎರಡನೇದು, ಈ ಟೊಬ್ಯಾಕೋ ನಿಕೋಟಿನ್ ಕಂಟೆಂಟ್ ಇರ್ತಕ್ಕಂಥ ಗ್ರೋತ್ ಮಾಡೋದು, ಅದನ್ನ ಗೌರ್ಮೆಂಟ್ ಲೈಸೆನ್ಸ್ ಕೊಡೋದು, ಮ್ಯಾನುಫ್ಯಾಕ್ಚರಿಂಗು ಮತ್ತು ಗೌರ್ಮೆಂಟ್ ನಲ್ಲಿ ಇರ್ತಕ್ಕಂಥ ಕಾನೂನುಗಳನ್ನ ಅವು ಕಾರ್ಯರೂಪಕ್ಕಾಗಿದಾವ ದಂಡುಗಳಿಂದ, ಅಥವಾ ನಾವು ಹೆಂಗೆ ಪಬ್ಲಿಕ್ಕಿಗೆ ಅವೇರ್ನೆಸ್ ಕ್ರಿಯೇಟ್ ಮಾಡ್ತಕ್ಕಂಥದ್ದು ಇಲ್ಲಿ ಪಬ್ಲಿಕ್ ಫೋರಮ್ನಾಗ ಇರ್ತಕ್ಕಂಥದ್ದು ಇಂಪಾರ್ಟೆಂಟ್ ಅಂತ ನನಗನ್ನಿಸ್ತದೆ ಸರ್, ಅಲ್ವಾ? ಇದು ಈ ನಿಟ್ಟಿನಲ್ಲಿ ನಾವು ಮಾಡ್ಬೇಕು ಹೊರತು, ಈಗ ನಾವು ಎಲ್ಲ ಎಜುಕೇಟೆಡ್ ಆದ್ವಿ, ಎಲ್ಲ ಏನು ಪ್ರಾಬ್ಲಮ್ಸ್ ಇದೆ ಅದಾದ್ಮೇಲೆ ನಾವು ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡ್ಲಿಕ್ಕೆ ಇಷ್ಟೆಲ್ಲ ವಿಚಾರ ಮಾಡ್ತಿದ್ವಿ. ಈ ನಿಟ್ಟಿನಲ್ಲಿ ನಾವು ಯಾವ ರೀತಿ ಕಾನೂನನ್ನ ಅನುಷ್ಠಾನಗೊಳಿಸ್ತಕ್ಕಂಥದ್ದು ಮತ್ತು ಅದನ್ನ ಬೆಳ್ಳಿಕ್ಕಿನ ಗೌರ್ಮೆಂಟ್ ಅವ್ರು ಯಾಕಂದ್ರೆ ಪರ್ಮಿಷನ್ ಕೊಡಬೇಕು, ಅಲ್ವಾ? ಆ ನಿಟ್ಟಿನಲ್ಲಿ ನಾವು ಬ್ರಾಡ್ ಆಗಿ ವಿಚಾರ ಮಾಡಿದಾಗ ಇವನ್ನೆಲ್ಲ ಹೆಂಗೆ ನಾವು ಅನುಷ್ಠಾನಕ್ಕೆ ತರಬೇಕು ಅನ್ನೋದನ್ನ ನಾವು ವಿಚಾರ ಮಾಡಿ ಪಬ್ಲಿಕ್ ಹಿಂಗೆ ಅವೇರ್ನೆಸ್ ಕ್ರಿಯೇಟ್ ಮಾಡ್ಲಿಕ್ಕೆ ವಿಚಾರ ಮಾಡಬೇಕು ಅಂತ ನನ್ನ ಅನಿಸಿಕೆ. ಯಾರಾದ್ರೂ ಇದ್ರ ಬಗ್ಗೆ ನಮ್ಮ ಅಧ್ಯಕ್ಷರಾತು, ನೀವಾತು, ಕುಲಕರ್ಣಿ ಅವರತ್ತು ಹೇಳಿದ್ರೆ ಸ್ವಲ್ಪ ಇದು ಸೂಕ್ತ ಏನೋ ಅಂತ ನನಗನ್ಸ್ತೈತೆ. ನಿಮ್ಮ ಇದ್ರ ಅಭಿಪ್ರಾಯ ಏನಂತ ನಾನು ಕುಲಕರ್ಣಿ ಸರ್ ಕೇಳ್ತೇನೆ.
ಸರ್, ಇದು ಗೌರ್ಮೆಂಟಿಗೆ ಒನ್ ಆಫ್ ದ ಮೇನ್ ಸೋರ್ಸ್ ಆಫ್ ಟ್ಯಾಕ್ಸ್.
ಅಲ್ಲಲ್ಲ, ಈಗ ನನ್ನ ಮಾತಾಡೋಂಥ ಅವಶ್ಯಕತೆ ಏನ್ ಬರುತ್ತೆ? ನಮಗ್ ಗೊತ್ತೈತೆ ಇದು ಲಿಕ್ಕರ್ ಇದರಿಂದ ಇಲ್ಲಿ ರೆವಿನ್ಯೂ ಹೆಂಗ್ ಬರ್ತೈತೆ, ಅಬಕಾರಿಯಿಂದ ಹೆಂಗ್ ಬರ್ತೈತೆ, ನಮ್ಮಿಂದಲೇ ಹೆಂಗ್ ಬರ್ತೈತೆ ಅಂದ್ರೆ ನಾವು ಇದು ಮಾಡಿದ್ರೆ ನಾವು ಮಾತಾಡ್ಕೊಂಡ ಗಾಳಿ ಗುದ್ದಿ ಮೈ ನುಸ್ಕೊಂಡಂಗೆ ಅಂತ ನಮ್ಮೆಲ್ಲರ ಒಂದು ಅನಿಸಿಕೆ ಇರುತ್ತೆ. ಬಟ್ ನಾವು ನಮ್ಮ ನಾಲೆಜ್ಗಳನ್ನ ಅಪ್ಡೇಟ್ ಮಾಡ್ಕೊಂಡು ಅದ್ ಬಂದಂತ ತೊಂದರೆಗಳನ್ನ ನಿವಾರಣೆ ಮಾಡ್ಲಿಕ್ಕೆ ಬೇಕಾದಂತ ನಾಲೆಜ್ಗಳನ್ನ ಕಲಿರುತ್ತೆ. ಬಟ್ ಅಲ್ಲಲ್ಲ, ನಿಜವಾದ ಮಾತು ಅಲ್ಲ
ಅಂತಂದ್ರೆ ಪ್ರತಿ ಟೈಮ್ ಗವರ್ಮೆಂಟ್ ಟ್ಯಾಕ್ಸ್ ಇನ್ಕ್ರೀಸ್ ಮಾಡಿದಾಗ ಆಕ್ಚುಲಿ ಮತ್ತೆ ಆಲ್ಕೋಹಾಲ್ ಸೇಲ್ಸ್ ಕಮ್ಮಿ ಆಗಿದೆ.
ಹೌದೌದೌದೌದು. ಅಲ್ಲ, ಇಷ್ಟೆಲ್ಲ ನಾವು ಹೋರಾಟ ಮಾಡೋದ್ಕಿಂತ ಇಷ್ಟೆಲ್ಲ ಕಳಕಳಿ ಐತಿ ಅಂತಂದ್ರೆ ಯಾರಿಗೆ ಕಳಕಳಿ ಇರ್ಬೇಕು ಅನ್ನೋದು ನಾವು ವಿಚಾರ ಮಾಡ್ಬೇಕಾಗಿತ್ತು ಅಷ್ಟೇ, ಮತ್ತೇನಿಲ್ಲ. ಬಟ್ ಆನ್ ದ ಕಾಂಟ್ರರಿ ವಿ ಆರ್ ಬೆನಿಫಿಟೆಡ್ ಮೋರ್ ಫ್ರಮ್ ಆಲ್ ದಿಸ್ ಪ್ರಾಬ್ಲಮ್ಸ್ ಇಂದ, ಅಲ್ವಾ? ನಾನು ಅನ್ಸಿದ್ದು
ಆಕ್ಟ್ ಅಲ್ಲಿ ಸರ್ ಗುಟ್ಕಾ ಬ್ಯಾನ್ ಮಾಡಿದ ತಕ್ಷಣ ಈ ಟೊಬ್ಯಾಕೋ ಕಂಪನಿದವರು ಪಾನ್ ಮಸಾಲ ಮಾಡಿದ್ರು.
ಅಲ್ಲ, ಎಂತೆಂತ ಅಡ್ವರ್ಟೈಸ್ ಹೆಂಗ್ ಕೊಡ್ತಾರ ನೋಡಿದ್ರೆ ಅನ್ಸಲ್ಲ ಅದನ್ನ. ಅಲ್ಲ, ನಿಜವಾಗಿ ಫೋಟೋ ಟಿವಿ ಒಳಗ ನೋಡಿಬಿಟ್ರೆ ಸೋಕಾಲ್ಡ್ ಅವ್ರಿಗೆ ಏನು ಕಡಿಮೆ ಇರಂಗಿಲ್ಲ, ಇದ್ರೊಳಗೆ ಅಡ್ವರ್ಟೈಸ್ ಕೊಡ್ತಾರೆ. ಮತ್ತೆ ನಮ್ಮ ಮಕ್ಕಳು, ನಾವು ಎಲ್ಲರೂ ನಮ್ಮ ಪಬ್ಲಿಕ್ ಹೆಂಗ್ ಹೋಗ್ತಾ ಇದಾರೆ. ಅಲ್ಲಲ್ಲ, ಇದು ನನ್ನ ಇನ್ನ ಜಸ್ಟ್ ಇದು ಔಟ್ ಆಫ್ ಇದು ಮಾತಾಡ್ತಾ ಇರೋದು. ಹೌದಲ್ಲ ಮೇಡಮ್? ಮೇಡಮ್ ಏನ್ ಹೇಳ್ತಾರೆ?
ಸರ್, ಲಕ್ಕೋಳ್ ಸರ್, ನೀವು ಹೇಳಿದ 100% ಕರೆಕ್ಟ್.
ಹೇಳಿ ಮೇಡಮ್.
ಈಗ 31st ಲಾಸ್ಟ್ ಮಂತ್ ಅಲ್ಲಿ ನಮ್ಮ IMA KSP ಇಂದ ತುಂಬಾ ಬ್ರಾಂಚಸ್ ಅಲ್ಲಿ ಒಳ್ಳೆ ಅವೇರ್ನೆಸ್ ಪ್ರೋಗ್ರಾಮ್ಸ್ ಎಲ್ಲ ಮಾಡಿದ್ದಾರೆ ಸರ್. ಅಂದ್ರೆ ಪಬ್ಲಿಕ್ ಗೆ
ಓಕೆ
ಮಾಡಿದ್ದಾರೆ,
ಅದು ಮಾಡೋದು ಇಂಪಾರ್ಟೆಂಟ್. ಎಸ್ ಎಸ್
ಮಾಡಿದ್ದಾರೆ.
ಎಸ್. ಹ್ಮ್
ತುಂಬಾ IMA-KSP ಪ್ರೋಗ್ರಾಮ್ಸ್ ಆಗಿದೆ. ಬಟ್ ನಾವು
ಹ್ಮ್
ಪಬ್ಲಿಕ್ ಸಬ್ ಕಮಿಟಿಯಿಂದ ನೀವೇನಾದ್ರೂ ಸಜೆಸ್ಟ್ ಮಾಡಿದ್ರೆ ನಾವು ಒಂದು ದೊಡ್ಡ ಪ್ರೋಗ್ರಾಮ್ ತರನೇ ಮಾಡಿ ಸ್ವಲ್ಪ
ಹ್ಮ್
ಮಾಡ್ಬೋದು ಸರ್. ಒಂದು IMS
ಅಲ್ಲಿಂದ
ಸಬ್
ಅಲ್ಲ
ಕಮಿಟಿಯಿಂದ
ಮೇಡಮ್ ಅಲ್ಲಿಂದ ಬಿಜಾಪುರದೆಲ್ಲ ಸ್ಟಾರ್ಟ್ ಆಗ್ಲಿ. ಕುಲಕರ್ಣಿ ಅವರು ನಮ್ಮ ಸುಜಯ್ ಕನ್ವೀನರ್, ಮತ್ತೆ ನೀವು ಚೇರ್ಮನ್, ನೀವು ಪದ್ಮ ಪ್ರಕಾಶ್ ಅವರು, ನಮ್ಮ ಸೆಕ್ರೆಟರಿ ಕರುಣಾಕರ್ ಇದ್ದಾರೆ, ಪ್ರೆಸಿಡೆಂಟ್ ಶ್ರೀನಿವಾಸ್ ಇದ್ದಾರೆ, ಎಕ್ಸಲೆಂಟ್ ವರ್ಕ್ ಮಾಡ್ತಾರೆ. ಗೋ ಹೆಡ್ ಸರ್.
ಬಿಜಾಪುರಲ್ಲಿ ರೇಡಿಯೋ ಟಾಕ್ ಕೊಟ್ಟಿದ್ದೀನಿ ಸರ್. ಇದರ ನೋ ಟೊಬ್ಯಾಕೋ ಡೇ ಅಂತ.
ಅಲ್ಲ, ಟಾಕಿಗಿಂತ ನಾವು ಪ್ರಾಕ್ಟಿಕಲ್ ಆಗಿ ಹೋಗ್ಬೇಕು ಸರ್. ಪ್ರಾಕ್ಟಿಕಲ್ ಆಗಿ ಮಾಡಿದ್ರೆ ಅಡ್ಡಿಲ್ಲ. ನಾವು 9 ಮಂದಿ ಇದೀವಿ ನೋಡಿ ಸರ್ ಈಗ ನಮ್ಗೆ, ಅಲ್ವಾ? ವಾಟ್ಸಪ್ನ ಇದ್ರೊಳಗೆ ಏನದರ ಏನೋ ಗೊತ್ತಿಲ್ಲ ನನಗೆ, ಯೂಟ್ಯೂಬ್ನಾಗೆ. ಅಲ್ಲಲ್ಲ, ಇದು ನಮ್ಮಲ್ಲಿ ಇರ್ತಕ್ಕಂಥದ್ದು ಅಂತ. ಯಾರು ಈ ಸಿಗರೇಟ್ ಸೇದ್ಲಾರ ಅಷ್ಟೇ 9 ಮಂದಿ ಇರ್ಬೇಕಿಲ್ಲ ಈಗ ಸದ್ಯಕ್ಕೆ ಅಂತಂತಂದ್ರೆ. ಅಲ್ಲಲ್ಲ, ಇದು ಸಬ್ಜೆಕ್ಟ್ ಗಿಂತ ಸುಮ್ನೆ ಹಂಗ ಜಸ್ಟ್ ಡಿಸ್ಕಷನ್, ದ ಪ್ರಾಕ್ಟಿಕಲ್ ಪಾಯಿಂಟ್ ಆಫ್ ವ್ಯೂ ಐ ಆಮ್ ಡಿಸ್ಕಸಿಂಗ್ ವಿತ್ ಯು ಆಲ್. ವೇರ್ ವಿ ಆರ್ ಗೋಯಿಂಗ್, ವಿ ಆರ್ ಫಾರ್ವರ್ಡಿಂಗ್ ಅಂತ ಹೇಳಿ, ಎಗನೆಸ್ಟ್ ಅಂತ ಹೇಳಿ. ಓಕೆ, ಥ್ಯಾಂಕ್ ಯು ಸರ್, ಥ್ಯಾಂಕ್ ಯು. ನಮ್ಮ ಪ್ರೆಸಿಡೆಂಟ್ಗೆ
ಅಕ್ಸೆಸಿಬಿಲಿಟಿ ತುಂಬಾ ಸಿಗ್ತಾ ಇದೆ ಸರ್ ಈಗ ಸ್ಟೂಡೆಂಟ್ಸ್ ಗಾಗ್ಲಿ. ಹೇಳ್ತಾರೆ ಅಷ್ಟೆಲ್ಲ ಅಂತ, ಅರೌಂಡ್ ಕಾಲೇಜಸ್ ಎಲ್ಲ ಕೊಡ್ಬಾರ್ದು, ಸಿಗ್ಬಾರ್ದು ಅಂತೆಲ್ಲ ಹೇಳ್ತಾರೆ. ಬಟ್ ಅಕ್ಸೆಸಿಬಿಲಿಟಿ ಇದೆ, ಅದರಿಂದ ಹೋಗ್ತಿದೆ. ಮತ್ತೆ ನೀವು ಸ್ವಲ್ಪ ಸ್ಟ್ಯಾಟಿಸ್ಟಿಕ್ಸ್ ಏನಾದ್ರು ಹೇಳ್ಬೋದಿತ್ತ ಡಾಕ್ಟರ್ ಕುಲಕರ್ಣಿ? ಅಂದ್ರೆ ಎಷ್ಟು ಅಂದ್ರೆ ನಾವು ಯು ಹವ್ ಟೋಲ್ಡ್ ಅಬೌಟ್ ಮಿಲಿಯನ್ಸ್ ಎಷ್ಟು ಡೆತ್ ಆಗ್ತಿದೆ ಅಥವಾ ಕನ್ಸ್ಯೂಮ್ ಮಾಡ್ತಿದ್ದಾರೆ ಅಂತ. ಎಷ್ಟೊಂದು ಪ್ರೊಫೆಷನಲ್ ಇರೋರೆ ತುಂಬಾ ಯೂಸ್ ಮಾಡ್ತಾರೆ ಸ್ಟ್ರೆಸ್ ಅಂತ.
ಹೌದು. ಅಂದ್ರೆ ಈ ಟಾಕ್ ಪರ್ಪಸ್ ಇನ್ನೊಂದು ಪರ್ಪಸ್ ಇತ್ತು ಮೇಡಮ್. ಅಂದ್ರೆ ಟು ಮೇಕ್ ಅವೇರ್ ಮೆನಿ ಡಾಕ್ಟರ್ಸ್ ದಟ್ ಯು ಕ್ಯಾನ್ ಹೆಲ್ಪ್ ಅ ಟೊಬ್ಯಾಕೋ ಯೂಸರ್, ಐದರ್ ಸ್ಮೋಕರ್ ಆರ್ ಅ ನಾನ್ ಟೊಬ್ಯಾಕೋ ಯೂಸರ್, by using some medication. So first thing is prevention. ಯಾರಿಗೆ ಪ್ರಿವೆನ್ಷನ್ ಮಾಡ್ಲಿಕ್ಕೆ ಆಗೋದಿಲ್ಲ, who are already consuming or who are using, there are different methods that will definitely work in helping them to stop the tobacco. So ಈ ತರ ಇದೆ ಅಂತ ಅವೇರ್ನೆಸ್ ಕೊಡೋದು ಮೋಸ್ಟ್ ಆಫ್ ದ ಡಾಕ್ಟರ್ಸ್ ಗೊತ್ತೇ ಇಲ್ಲ ಇದು. ಸೊ ಯಾವ ಡ್ರಗ್ಸ್ ಯೂಸ್ ಮಾಡ್ಬೇಕು ಅಂತಾನೂ ಗೊತ್ತಿಲ್ಲ, ಹೇಗೆ ಯೂಸ್ ಮಾಡ್ಬೇಕು ಅಂತಾನೂ ಗೊತ್ತಿಲ್ಲ. But especially non experiential nicotine replacement therapy has helped many people, madam. First thing, it has helped them reduce the number of cigarettes, and for some people it has definitely reduced, helped them completely quit the smoking. So doctors should also be aware that you can help a person who is already smoking. So prevention ಆಗ್ಲಿಲ್ಲ ಅಂದ್ರೆ at least secondary ಟ್ರೀಟ್ಮೆಂಟ್ ನಲ್ಲಿ ನಾವು ವಿ ಕ್ಯಾನ್ ಟ್ರೀಟ್ ದೆಮ್ ಅಂಡ್ ಹೆಲ್ಪ್ ದೆಮ್ ಪ್ರಿವೆಂಟ್ ಟು ಕಂಟಿನ್ಯೂ ಸ್ಮೋಕಿಂಗ್.
ವೆರಿ ನೈಸ್. ಮತ್ತೆ ಬೇರೆ ಯಾರಾದ್ರೂ
ಸರ್? ಅದೇ ಅಡ್ವರ್ಟೈಸ್ಮೆಂಟ್ ಪ್ರೊಹಿಬಿಷನ್ ಬಗ್ಗೆ ಹೇಳಿದ್ರಿ. ಅದ ಒಂದು ಕೇಸರಿ ಅಂತ ಅಂದ್ಬಿಟ್ಟು ಅಡ್ವರ್ಟೈಸ್ಮೆಂಟ್ ಎಲ್ಲಾದ್ರಲ್ಲೂ ಬರ್ತಾ ಇರುತ್ತೆ ಸರ್. ಅದನ್ನ ಚೆಲ್ಲೋದು, ಎಲ್ಲರ ಮೇಲೆ ಬೀಳೋದು, ಅದ್ರ ಬಗ್ಗೆ ನಾವು IMA ಅಂತ ಏನ್ ಮಾಡಕ್ಕಾಗಲ್ಲ.
ಅದೇ ಪ್ರಾಕ್ಸಿ ಅಡ್ವರ್ಟೈಸ್ಮೆಂಟ್ ಅಥವಾ ಸರೋಗೇಟ್, ಅದು
ಸರ್
ಕೋಪ್ಟಾ ಆಕ್ಟ್ ನಲ್ಲಿ ಒಂದು ಲೂಪ್ ಹೋಲ್ ನ ಯೂಸ್ ಮಾಡ್ಕೊಂಡು ಅವ್ರು ಮಾಡ್ತಾ ಇದ್ದಾರೆ. ಕೇಸರಿನೂ ಇರಂಗಿಲ್ಲ, ಅಲ್ಲಿ ಕೆಳಗಡೆನೆ ಬರ್ದಿರುತ್ತೆ ಕೇಸರಿನೂ ಇರಂಗಿಲ್ಲ ಅಂತ ಹೇಳಿ, ಅದನ್ನು ಬರ್ದಿರುತ್ತೆ. ಬಟ್ ಅಡ್ವರ್ಟೈಸ್ಮೆಂಟ್ ನಲ್ಲಿ ಆ ತರ ತೋರಿಸ್ತಾ ಇದೆ. ಇದು ಸರೋಗೇಟ್ ಅಡ್ವರ್ಟೈಸ್ಮೆಂಟ್. ಆಕ್ಚುಲಿ ದೇ ವಾಂಟ್ ಟು ಪ್ರಮೋಟ್ ಟೊಬ್ಯಾಕೋ, but they are using pan masala to promote tobacco.
ಅದೇ ನಾವೀಗ IMA ಇಂದ ಏನು ಮಾಡಕ್ಕಾಗಲ್ಲ ಸರ್, ಈ ತರ ಮಾಡೋ ತಪ್ಪು ಜನರಿಗೆ ಅಂತ.
ಚೇಂಜ್ ಮಾಡಿಸ್ಬೇಕು ಮೇಡಮ್. ಆಕ್ಟ್ ಅಲ್ಲಿ ಚೇಂಜ್ ಮಾಡಿಸಿದ್ರೆ ಅಷ್ಟೇ ಈ ಕಂಪನಿಗಳು ಈ ತರ ಸರೋಗೇಟ್ ಅಡ್ವರ್ಟೈಸ್ಮೆಂಟ್ ಅಥವಾ ಪ್ರಾಕ್ಸಿ ಅಡ್ವರ್ಟೈಸ್ಮೆಂಟ್ ಕೊಡೋದನ್ನ ನಿಲ್ಲಿಸ್ತಾರೆ. ಆಕ್ಟ್ ಅಲ್ಲಿ ಏನು ಆ ತರ ಅಡ್ವರ್ಟೈಸ್ಮೆಂಟ್ ಕೊಡಬಾರ್ದು ಅಂತ, ಸರೋಗೇಟ್ ಅಡ್ವರ್ಟೈಸ್ಮೆಂಟ್ ಕೊಡಬಾರ್ದು ಅಂತ ಏನೂ ಇಲ್ಲ. ಸೊ ಆದ್ರಿಂದ ಆ ಲೂಪ್ ಹೋಲ್ ನ ಯೂಸ್ ಮಾಡ್ಕೊಂಡು ಇವ್ರು ಮಾಡ್ತಾ ಇದ್ದಾರೆ.
That's what we have to give a letter so that anything can be done to stop these advertisements. ನಮ್ ಕಡೆಯಿಂದ ಅವ್ರು ಮಾಡ್ತಾರೋ ಬಿಡ್ತಾರೋ ಬೇರೆ.
ಇದೊಂದು ಪ್ರೊವಿಷನ್, ಸರೋಗೇಟ್ ಅಡ್ವರ್ಟೈಸ್ಮೆಂಟ್ ಗಳನ್ನು ಸಹ ಕೊಡುವ ಹಾಗಿಲ್ಲ ಅಂತ ಹೇಳಿ ಅದನ್ನ ಆಕ್ಟ್ ಅಲ್ಲಿ ಆಡ್ ಮಾಡಿಸ್ಬೇಕಾಗುತ್ತೆ. ಆಕ್ಟ್ ಅಲ್ಲಿ ಬರದೇ ಇದ್ರೆ ಈ ಕಂಪ್ನಿಗಳು ಯಾರು ಅದನ್ನ ಫಾಲೋ ಮಾಡೋದಿಲ್ಲ.
ಕಂಪನಿ ಮಾಡೋದಿಲ್ಲ ಸರ್, ಬಟ್ ಕ್ಯಾನ್ ವಿ ಡೂ ಅಂತ ನಮ್ದು ಅಧ್ಯಕ್ಷರು ಮತ್ತೆ
ಅದೇ
ಕಾರ್ಯದರ್ಶಿ
IMA
ಆಲೋಚನೆ ಮಾಡಿ
ಕೇಸ್ನಿಂದ
ಲೆಟರ್
ಲೆಟರ್
ಕಳ್ಸಿದ್ರು.
ಕೊಡ್ಬೋದಾ ಅಂತ ಮೇಡಮ್ ಹೇಳ್ತಾ ಇದ್ದಾರೆ.
ಹಾ ಮಾಡ್ಬೋದು
ಹೌದು ಪ್ರೆಸಿಡೆಂಟ್.
ಹ್ಮ್ ನಮ್ ಕಡೆಯಿಂದ ಸರ್ ಅದು ಆದ್ರೆ ಆಯ್ತು ಹೋದ್ರೆ ಹೋಯ್ತು, ಬಟ್ ನಮ್ಗೊಂದ್ ಸಮಾಧಾನ ಆದ್ರೂ ಇರುತ್ತೆ ನಾವು
ಒಂದ್
ಟ್ರೈ
letter
ಮಾಡಿದೀವಿ
ಕೊಡು.
ಅಂತ.
ಆಕ್ಚುಲಿ ಜೈಪುರ್ನಲ್ಲಿ ಈಗ ಏನ್ ನಾವು ಅಡ್ವರ್ಟೈಸ್ಮೆಂಟ್ ಸಿಗರೆಟ್ ಪ್ಯಾಕೆಟ್ ಅಲ್ಲಿ, ಗುಟ್ಕಾ ಪ್ಯಾಕೆಟ್ ಮೇಲೆ ಅಥವಾ ಟೊಬ್ಯಾಕೊ ಪ್ಯಾಕೆಟ್ ಮೇಲೆ ಕ್ಯಾನ್ಸರ್ ಫೋಟೋಸ್, ಅದು ಫೋಟೋಸ್ ನೋಡ್ತೀವಲ್ಲ ಮೇಡಮ್, ಇದು ಆಕ್ಚುಲಿ ಜೈಪುರ್ ರಾಜಸ್ಥಾನ್ ಇಂಡಿಯನ್ ಮೆಡಿಕಲ್ ಅಸೋಸಿಯೇಷನ್ ಫೋರ್ಸ್ ಮೇಲೆ ಈ ಫೋಟೋಗ್ರಾಫ್ಸ್ ಅನ್ನ ಹಾಕೋತರ ರಾಜಸ್ಥಾನ್ IMA ಮಾಡ್ತು ಮೇಡಮ್. ರಾಜಸ್ಥಾನ ಇಂಡಿಯನ್ ಚೆಸ್ ಸೊಸೈಟಿನೂ ಮಾಡ್ತು. ಅವ್ರ ಎಫರ್ಟ್ಸ್ ಲಿಂತ ಸುಪ್ರೀಂ ಕೋರ್ಟ್ ಅಲ್ಲಿ ಹೋಗಿ ಫೈಟ್ ಮಾಡ್ಬಿಟ್ಟು ಇದನ್ನ ಫೋಟೋ ನಾವು ಕಂಪಲ್ಸರಿ ಟೊಬ್ಯಾಕೊ ಪ್ರಾಡಕ್ಟ್ಸ್ ಮೇಲೆ ಬರೋ ತರ ಮಾಡಿದ್ದೆ ರಾಜಸ್ಥಾನ್ IMA ಅಂಡ್ ಜೈಪುರ್ ಇಂಡಿಯನ್ ಚೆಸ್ ಸೊಸೈಟಿ ಬ್ರಾಂಚ್. ಸೊ ಮಾಡಿದ್ದಾರೆ, IMA ದಿಂದಾನೇ ಈ ಎಫರ್ಟ್ ಇದೆ ಮೇಡಮ್. ಬಿಕಾಸ್ ಆಫ್ ದೆಮ್ ಓನ್ಲಿ ಅಟ್ಲೀಸ್ಟ್ ಆ ಕ್ಯಾನ್ಸರ್ದು ಫೋಟೋ ಆದ್ರೂ ಸಿಗರೆಟ್ ಪ್ಯಾಕೆಟ್ ಮೇಲೆ ಅಥವಾ ಗುಟ್ಕಾ ಪ್ಯಾಕೆಟ್ ಮೇಲೆ ಕಂಡು ಬರ್ತಾ ಇದೆ. ದಟ್ ಈಸ್ ಮೇನ್ಲಿ ಬಿಕಾಸ್ ಆಫ್ ಎಫರ್ಟ್ ಆಫ್ ಡಾಕ್ಟರ್ಸ್ ಫ್ರಮ್ ರಾಜಸ್ಥಾನ್.
ಪದ್ಮ ಮೇಡಮ್ ಒಂದು ತಕೊಳ್ಳಿ ಇನಿಷಿಯೇಟಿವ್ ಪಬ್ಲಿಕ್ ಹೆಲ್ತ್ ಅವೇರ್ನೆಸ್ ಇಂದ.
ಪಬ್ಲಿಕ್ ಹೆಲ್ತ್ ಅವೇರ್ನೆಸ್ ಮತ್ತೆ
ಅಟ್ಲೀಸ್ಟ್ ಕ್ಯಾನ್ಸರ್
ಅಟ್ಲೀಸ್ಟ್ ಲೆಟರ್ ಆದ್ರೂ ನಾವು ಪ್ರಪೋಸ್ ಮಾಡ್ಬೋದು ಮೇಡಮ್, ಕೊಟ್ಟು ಬರ್ಬೋದು ಹೆಲ್ತ್ ಮಿನಿಸ್ಟ್ರಿ.
ಅದೇ ಒಂದ್ ಹಂಗ್ ಬರೋ ಹಂಗೆ ಮತ್ತೆ ಈ ತರ ಅಡ್ವರ್ಟೈಸ್ಮೆಂಟ್ ಗಳನ್ನ ಕಮ್ಮಿ ಮಾಡೋ ಹಂಗಾದ್ರೂ ಮಾಡಿದ್ರೆ ಅಟ್ಲೀಸ್ಟ್ ಎಷ್ಟು ಕ್ಯಾನ್ಸರ್ಗಳು ಅದು ಇದು ಅವಾಯ್ಡ್ ಆಗ್ಬೋದು. ಅಟ್ಲೀಸ್ಟ್
ಹೌದು
ಒಂದಾದ್ರೂ ಕೂಡ ಲಾಭನೇ ಅಲ್ಲ, ಯಾರೋ ನೋಡ್ಬಿಟ್ಟು.
ಕರೆಕ್ಟ್. ಪ್ರೆಸಿಡೆಂಟ್ ಹತ್ರ ಮಾತಾಡ್ತೀನಿ ಮೇಡಮ್, ಇದು ಟೇಕ್ ಎ ಸೀರಿಯಸ್ ನೋಟ್.
ಎಸ್
ಥ್ಯಾಂಕ್ ಯು
Yeah. ಥ್ಯಾಂಕ್ ಯು ಸರ್, ಇಟ್ ವಾಸ್ ಅ ನೈಸ್ ಪ್ರೆಸೆಂಟೇಷನ್.
ಥ್ಯಾಂಕ್ ಯು.
Thank you. Thank you all.
ಅನುರಾಧ
Good night.
madam.
Good night, madam. Good night.
ಗುಡ್ ನೈಟ್.
Good night. Good night.
ಗುಡ್ ನೈಟ್. ವೋಟ್ ಆಫ್ ಥ್ಯಾಂಕ್ಸ್ ಹೇಳ್ಬಿಡಿ ಕಾಗಲ್ಕರ್. ಡಾಕ್ಟರ್ ಕಾಗಲ್ಕರ್.
ಗುಡ್ ನೈಟ್ ಹೇಳಿ ಆಯ್ತಲ್ಲ ಅವರು.
10 o'clock ಆಯ್ತಲ್ಲ, ಐ ಥಿಂಕ್ ಸರ್ ಇಸ್ ಸ್ಲೀಪ್. ಡಾಕ್ಟರ್ ಕಾಗಲ್ಕರ್ ಜಸ್ಟ್ ವೋಟ್ ಆಫ್ ಥ್ಯಾಂಕ್ಸ್ ಮಾಡ್ಬಿಡಿ.
ಮೇಡಮ್ ನೀವೇ ಹೇಳಿ, ಆನ್ ಮಾಡೋದು.
Okay, on behalf of IMA KSB Public Health Subcommittee, vote of thanks, sincere thanks to Dr. Kirtivardhan Kulkarni sir for your elaborative talk, and thank you so much for accepting our words, and thank you so much to our Honorable President IMA KSB, Dr. Srinivas sir. Thanks a lot to Dr. Karnakar sir, Secretary. Anuradha madam, she's online, and thanks a lot to one and all for your precious time, spending your precious time at this occasion. Thank you once again. Good night.
Thank you.
Thank you.